So what we have here is some of the loops that are involved in the uh, overall scenario of the cerebellum function. So in the red one, we see that as the brain sends a command for initiation of movements, we see that it sends a copy of this to the cerebellum. And when it's in the cerebellum, it undergoes the circuitry that we talked about, which comes out through a deep nucleus. And this is the dentin, the one in red. And the output is such that it innervates the thalamus before it goes on to the cortex, and there we have the final modified impulse that descends. Then we have the second one in blue. Now this loop is initiated by proprioceptive information. Now, before any of these activities have to happen, you have to know where the muscles are, or where you are in space and time proprioception. So this information is sent up through motor fibers and through the inferior peduncle. And we see that after it undergoes the circuitry modifications, circuitry fine-tuning in this case, it comes out through the fastigial nucleus, and synapses on the vestibular nucleus, and also on the reticular formation. Reticular formation, I always remember it as the part of my CNS that keeps me awake, so to speak. So this is very informative to the higher cortex. So if I want to keep where am I in certain times. And of course, a large modification of this comes in through the climbing fibers from the inferior olivary nucleus. So in this component, what is happening is we receive excitation, or excitation is received from the rubrospinal tract itself. Okay, so from the rubrospinal tract, I'll pick it up from there. Okay, you have the inferior olivary, which then goes through the inferior peduncle. And upon stimulation of the cerebellum, we see that modulation occurs, and the output is through interpose. Okay, so you have the interpose deep nuclei, and this goes back. Okay, it goes back to I beg your pardon. Sorry for this. It goes back to actually the red nucleus. So the red nucleus is way back here. So it goes back to the red nucleus to go and innervate it. And this loop is for a continuous modification of excitation of the plexus. If you do remember what the rubrospinal tract does, it's exactly that. So you want this particular component to be modified. After all these modifications, we see that the final impulse that is sent down to the particular muscles is got modification of the muscle itself in terms of flexors. It's got modified proprioceptive information, and also modified cerebellum loop function. And this is all to, number one, after the motor unit receives the impulse, we also need, first of all, initially, this is all to ensure that before the efferent, or before the descending fiber send the information, everything that needs to be known is known about what you're supposed to do about the movement of the muscles. Now, after the motor units receive the impulses, we then need feedback, okay, to the cerebellum. Now, this is called reafference. Now, in the reafference, this is just to inform the cerebellum again that the muscles have changed where they are in space and in time. So if you're looking at it holistically, let's say you want to kick a ball. So the first thing that will happen is the prefrontal the prefrontal cortex is going to send impulses, and these impulses are going to go to the motor cortex. So from the motor cortex, you see that a copy, okay, an efferent copy will be sent to the cerebellum. Once that happens, you see that the cerebellum also receives information. Okay, it receives information. What type of information? Proprioception. So with this information, it knowing what the body wants to do and it knowing where the body is, you find that there is modification that occurs of the final, okay, of the final impulse. So once this impulse is now modified, we see several things. First of all, the excitation that is coming from the cerebrospinal is also modified through the climbing fibers, and this is to increase or reduce the exertion on the force. Okay, so there's also the role of the climbing fibers. So with all of this, the proprioception, the climbing fibers role, now you're able to send impulses to the leg. If you want to kick a ball, able to send impulses to the leg or through descending fibers. And after the leg receives, or the leg muscle receives this information, it then sends back the information to the cerebellum to sort of tell the cerebellum the new state or the new position. And why? Part of the reason is that the cerebellum needs to be kept updated of where things are in space and time. But the other reason is that you also need to sort of compare the actual movement that has taken place, the actual movement of the muscle, to that one that was intended, so that if there's any corrections that need to be set out, this is the time that the corrections have to be set out. We'll see how this comes up in disease. But holistically, this is what we're talking about. So when we talk about disease, what do we see? First disease that I would like to just bring about is that the cerebellum itself receives information, receives sensation from the ipsilateral part of the spinal cord and the contralateral part of the upper cortex. So if you're talking this way, you're saying it receives like that, and then when going down, it's on the same side. Okay, so this implies that its information is on the same side. So if a lesion has to happen in the left peduncular area, okay, so this is left and this is right. So if it had to happen in this area, there would be ataxia on this side of the body. Okay. Now, what is ataxia? Ataxia is just incoordination due to errors in the rest, the range, the force as well, and the direction of movement. So you see that in these individuals, you have voluntary movement that is highly abnormal, and if they try to touch an object, let's say with their finger, so if they were touching, let's say, their nose, and this was their finger, okay, so their finger, they would actually go all this way before getting to the nose. So in these individuals, you see that there is overshooting, okay, because there's no error correction. And in overshooting, you can see a typical example is pap pointing. Now, pap pointing is also known as dysmetria. Alright, so promptly initiate a gross corrective action, but the correction overshoots the other side in these individuals, and then consequently you find that the finger oscillates back and forth. And in this type of oscillations, you find a very intention tremor. Other diseases that you find are the inability to put on brakes. Okay, you can't put on brakes. So if these individuals are told to hold their hand still, and then somebody pulls it, once somebody lets go of their hand, you will notice that they will not have the ability to let it stay there. So the flexion of the forearm against resistance is quickly checked when the resistance force is suddenly broken off. So when you just break it off, you see that the patient cannot break the movement of the limb, and you see that it will move backward in a wide arc, and this abnormal response is known as a rebound phenomenon. There are other diseases that where you have an inability to perform rapidly alternating opposite movements. Patients with cerebellar diseases have find it difficult to perform actions that involve simultaneous motions, and such movements. For example, if you're moving your right hand to the right and your left hand to the left, you find that individuals are not able to do this. This is known as dysdiadochokinesia. Yeah. All right. Maybe just one more abnormality. So motor abnormalities usually that are associated with the cerebellum, they vary depending on the region. So the major dysfunction that you see is after the damage of the vestibular cerebellum, such as ataxia, disequilibrium, stigma, and then damage to the thymus and the procedure nucleus, which is part of the spinal cerebellum, will lead to a disturbance in the control of the axial and trunk muscles during attempted anti-gravity movements or scanning speech. And then the degeneration of this portion of the cerebellum can also result sometimes in deficiencies in alcoholic or malnourished individuals. Having said that, I just want you to have a practice exercise on our platform. Ensure that you go there immediately after this class and answer a few questions about what we have put across today. So that's all we're going to talk about when it comes to the cerebellum. In the next lecture, we'll be talking about the basal ganglia.